All right, everybody, welcome back to a new video for our manual therapy forum. What I want to show today is something to do with the upper cervical spine, specifically C1, C2 with the dysfunction. I just see a lot, and I don't know if it's just some kind of thing that I'm seeing more of because I'm paying more attention to it, which is quite possible, but I really think it's something that I'm assuming other people miss, and it really has to do with just how we assess range of motion within C1, C2, and then how we're going to improve that range of motion. So on the model here, you can see, cranium, C1, C2, C3. And part of the reason why I'm also showing this is that I'm seeing a ton of patients that have really significant C2-3 dysfunctions, problems, hypomobilities, whatever you want to say, and specifically to an anterior superior kind of glide. Where it's lost that motion, and it's pretty significant of how bad it is. And one of the common things I find with that is this loss of movement for C1-2. So if we're talking about this left side, where this C1-2 is not gliding posterior and inferior. So a lot of times I see that as a significant loss of movement at C1-2. And what I'm going to show you next is, I think, one explanation for why that is, or why it kind of gets missed. So there's a number of ways to look at that movement. You can do your standing range of motion, things like that. But one of the well-documented ways of assessing C1-2 rotation is full flexion of the head and neck, and then rotate however far you can to each side. And the normal range of motion should be about 45 degrees. And if somebody's limited with that, you would say that limitation is occurring at C1-2. However, there's some goods and bads with that test. Yes, it is documented within the literature, but there's some negatives behind it. You also have other ways of assessing whether or not you want to fully side bend this way and then rotate, or if you want to shear at the mid-lower cervical spine and rotate that way. The problem with those is, if you just assume that C1-2 rotates and does nothing else, you're really missing where a dysfunction could be. So on a patient, when you rotate your head to the left on this right side, that C1 vertebrae is gliding down and forward. On the left side, when you rotate left, it's gliding down and back. So when that happens, you could just assume, and some people do, that it's just not rotating. And so you could do different manipulations that you learn, or mobilizations, or muscle energies, or FMs, or other things to improve that, but you may not be as specific as you should in terms of finding a dysfunction. Or maybe your mobilizing or manipulating hand is only on this one side to improve that movement, and you're really missing literally half of that mobility. So what I'm going to show you real quick here is one quick way of assessing that glide and supine. And more or less, I'm going to have my fingers blocking here at C2. So I'm going to find C2 spinous process. I'm going to go out lateral, palpate right here on this lamina and posterior part of the facet here at C2. And then I'm just going to take the head and rotate it however far I can to the left in this case, to see how much mobility is there at this C1-2 vertebrae. And that's kind of what I'm looking at. And you'll be able to tell really quickly if there's any loss of movement there. So for him, palpate the spinous process, which I know you guys won't be able to see, but then I'm going to come out lateral. I'm going to fixate that part. I'm going to fixate my fingers right on that part. So I'm holding that C2 vertebrae in place, and then I can rotate through his head to the left and assess an infield. So I can hold that in position and also do a spring test where my left hand is springing anterior and superior, bringing C2 up underneath C1 and checking an infield like that. So luckily, our patient here is not that bad in this regard, especially going on the right side. To the left is still a little bit hypomobile, but I mean, this is not really a good demonstration. But anyway, that's how it would look in terms of an assessment. So some of you may be familiar with a way of mobilizing where, you're seated and the patient's seated and you're grasping C2 and you're kind of wrapping around like this, and you can mobilize that way. But here, I can just turn this into a real simple mobilization by blocking that C2 and then just resist his head turning, so don't let me turn you to the left. As he relaxes, I can take up that slack. Or I could say, okay, turn to the left. And I try and hold that way, whichever one works the best, and let it go. So each time I could take up the slack by turning his head further, or with my left hand gliding that C2 up underneath C1 even further. So either one of those can work pretty well and effective, especially if somebody has a dysfunction that's been there long enough and it's going to be nice and stiff. It can be kind of hard to do certain mobilizations that take a long time to stretch out. So this can be a lot more comfortable as the therapist, so that it doesn't take a whole lot of effort on my part, and I can just sit here and hang out and go through that and wait. So that's one option, just one of many. I'm not saying you have to do it that way, but that's one way I found out that works pretty well. Give it a shot. Make sure you're checking this at C1-2 in terms of mobility if you're not. If you have any questions or comments, leave them down below in the comments section. Always look for us on different social media or podcast platforms. As always, thanks for watching. See you later.